Hi, this is Ralph Moss. This is part of my ongoing series about my own treatment for prostate cancer. Today is April 23rd. This is my second video that I'm doing in a series. And my first dry run of radiation therapy will be in 2 days from now. I'll report on that when it happens. But today I wanted to continue my discussion of how I made the decision to have radiation therapy. A big part of it had to do with advances that have been made in radiation since almost 10 years ago when I was first diagnosed with prostate cancer. And it has to do with, especially with a procedure or a device called SpaceOAR. That's the word space and OAR. It's a kind of hydrogel that can be injected or inserted in your body between the prostate gland and the rectum in order to reduce the chances of having side effects, late stage side effects of the radiation treatment. As you may know, in males, the prostate and the rectum are side by side and impinge on each other, but a doctor named John Sylvester, about 15 years ago, came up with the idea of injecting a gel called PEG. It's a hydrogel, and they put this in between the two organs, and that creates a space of at least 1 centimeter, and that makes a difference in terms of the chances of getting side effects, especially pain and bleeding in the rectum, which of course is very distressing. So we're lucky that this has been approved by FDA, and we have the numbers. We have a large clinical trial that was done, and I'll give you those numbers in a minute. But to be honest, even though I've spent a lot of my life in examining cancer alternatives, I wasn't all that aware of the advances like this that have been made in treating prostate cancer until I had to deal with it myself. The agent that's injected in SpaceOAR is polyethylene glycol. And this is a very common ingredient that's used in many things. I was checking my own medicine cabinet, came across this toothpaste that was given to me by my dentist, and I've used it occasionally, and among the ingredients it says PEG 8, which is a form of polyethylene glycol. So this is something widely used. It's non-toxic, and basically the procedure that I had a couple of weeks ago it required anesthesia, which was the most difficult, if you will, part of the whole procedure. They put you out, and you're out for about half an hour. And during that time, they basically inject this material into your body, into the space between those two organs, and it's a non-event, if you will. I mean, I couldn't say that I would ever know that this thing was in me. And it's absorbed slowly by the body. By 6 months, generally speaking, it's gone. And there are CAT scans and stuff to show that this is the case. And as I say, I'm not even aware that it's there, but it creates enough of a barrier for the radiation that it has a very big effect in terms of the treatment. The negative effects of radiation, which are basically to burn areas of the body that are not implicated in the cancer. You just want to have them attack the cancer cells, not the normal cells. So in the clinical trial, there were hundreds and hundreds of patients, of men with prostate cancer, and they were looking, first of all, at rectal pain overall. At 3 months, the rectal pain in the people who got the spacer was 2.7 but in the people who got a dummy type of treatment, placebo type of treatment, it was 11.1%. So there was a 76% difference between the two groups at 3 months. In late grade 1 rectal toxicity, in the group that got the spacer, there was 2% of them had late rectal toxicity, which could be various things like bleeding or constipation, diarrhea, that sort of thing. And in the group that didn't get the spacer, it was 9.2%. That was a 78% decrease in the toxicity in the people between 3 and 37 months was how they judged this. In terms of late grade 1 or greater urinary incontinence, loss of urine, in the people who got the spacer, it was 4%, and in the control arm, the people who didn't get it, it was 15%. Again, a 73% difference. And in the late grade 2 rectal toxicity, there were 0% in the more advanced type of rectal problems. It was 0% versus 5.7% in the people who didn't get the spacer. So that's 100% relative to the controls, 100% control. So this is extremely encouraging. And some people have asked me, well, why didn't you go for proton therapy? I'm fortunate in that where I live, I'm only within less than an hour drive to a proton therapy center. And I think it has a good reputation. And I was in touch with them, and I have visited other proton therapy centers. But I think that aside from the fact that proton therapy would require me to be, taking a lengthy drive through traffic for 30 times, which is essentially what the span of treatment would be, it lost much of its advantage as SpaceOAR, or this injected hydrogel, came up in prominence, because the reason for doing the proton was that it more accurately pinpointed the cancer than the old-fashioned style of intensity-modulated radiation therapy. Even if that's true, with the SpaceOAR, it kind of leveled the playing field. And so now I can have treatment at a very good center, only 10 or 15 minutes from my home, and I feel very comfortable with that. And I think you can see what a tremendous advantage it is to be able to sort of be put to sleep for half an hour, and they do something that there was no bleeding, there was no pain, there's nothing. I mean, I wouldn't even know that anything had happened. So I'm very comforted by that fact, and I think that given also the diet that I intend to follow and the various special procedures and foods and stuff that I will be detailing in the next few months, I'm anticipating a good outcome, both medically, but also very much on my mind in terms of side effects, which I think many men would be concerned with. So this should be important, reassuring news. If you or someone you love is facing prostate cancer or prostate cancer therapy, definitely jot down the words SpaceOAR, just like an oar in a boat, otherwise known as a hydrogel spacer. It's been around for a couple of decades now, but it's only getting more prominently understood now that it's routinely recommended through the guidelines and also paid for by Medicare and most insurance plans. So I think this could be very important in terms of your decision making and what you might expect to happen after the treatment. So Thank you for listening. This is Ralph Moss.